Good evening, everybody. This is Mark Jones. I'll be presenting to you on diverticular disease this evening. Diverticulosis is the presence of diverticula, which is basically sacs or protrusions in your colon. Weak points develop in the muscular wall. If you think about the colon, it's sort of like a hose with rings around it, and the spaces in between the rings of strong muscle is muscular striated tissue. So when it gets increased pressure, it bulges out. If you take a look at the black and white picture on the left, it shows you get kind of pressure on the colon wall and it pushes out a little pouch. Diverticulosis is the presence of these pouches. Diverticulitis is when you get some sort of infection, bleeding, perforation, or other complication from the pouch. Diverticulosis, it's not a age or specific disease. It normally occurs more as you get older because of the additional pressure placed on your colon over time and the decreased muscle stratification it pushes through. So 20% chance of getting it age 40, 60% by age 60. Females less likely to have it than males, according to Pemberton. Risk factors they list are older age, males, smoking, and elevated body mass. Connective tissue disorders such as Ehlers-Danlos syndrome, Marfan syndrome are also common genetic muscular strengthening problems that could also affect your diverticulosis or your colon striated muscle. Approximately 4% of the patients that get diverticulosis develop a diverticulitis. So it's not a huge percentage. The mean age for admission for acute diverticulitis in the hospital is 63 years old. So pathophysiology, diverticula developed at weak points. The colon, the vasa recta penetrate into the circular layer of the colon, that connective tissue or connective muscle in between the stronger rings. There are a lot of theories out there as to why this happens. Some think it's pressure, increased pressure placed on the wall over time, but there's been no theory that's been tested out and been proven. So you're probably going to hear 10 or 12 different theories. None of them have any more validity than the other. The important thing to remember is that diverticulitis, once you get the pouches, things can accumulate in the pouches and the pouches can start to push into other tissues. So you can get an abscess where you get material trapped inside the pouch that becomes infected. They sometimes can drain those. You can get a fistula connecting your colon to other organs and tissues in the abdomen. They're much more complicated. Usually you end up with bleeding there. When the bowel becomes irritated, it doesn't work well, so you can get paralytic ileus, you can get a bowel obstruction, and you can also get just plain perforation through the bowel wall. Diverticulosis, according to Pemberton Strait, is believed to be anticipated food particles leading to inflammation, focal necrosis at the spot that eats through the wall, and you get micro or macro perforation. There is a lot of information out there. Some of it's not scientifically backed, but it's commonly out there talking about avoiding seeds, avoiding nuts. None of that tested out to be true in a bunch of studies. They do indicate that a reasonable dietary fiber level, not a hyper dietary fiber level, with fruits, vegetables, and grains and vegetarian have had a decreased incidence of diverticulitis, but it's only like 10% less than average, so it's not earth-shaking. Normally, diverticulosis is symptom-free. You get these pouches, and the pouches by themselves don't cause pain, They don't bleed. They're just pouches. You don't even feel them. What happens is when the pouches becomes inflamed, you get abdominal pain, and sometimes you get blood detected in the stool, either um, streaks of blood or just kind of a maroon in the stool. There is some research that says that nonsteroidal anti-inflammatory drugs, aspirin, and antiplatelet medications have been identified as risk factors for diverticular bleeding. This isn't a real shocker. If you get a hole in your colon that goes into a highly vascular area and you have medications on board that prevent clotting, then the holes bleed. The most common complaint with diverticulitis is abdominal pain. It's usually defined as constant. I wish I could tell you that there was a particular place. There's a long breakdown in two of the different studies. Pemberton does a nice write-out that talks about whether it's transverse colon, ascending colon, descending colon. The end answer is you can get diverticulitis in any one of the colons. There's percentages based on race and sex and stress level, but anybody can get diverticulitis in any part of the colon. So if you get a perforation and it becomes infected, you can have a fever. Bowel irritation can cause constipation, in some cases, bowel obstruction. Atypical presentation of older adults. There's not really an atypical presentation in older adults. However, the abdominal pain and hematochezia, that's the blood in the stool, can be confused with other geriatric complaints of bowel issues related to age. So if you ever do any work in long-term care, they track bowel movements like the US government tracks nuclear weapons and storage sites. Bowel movement every 3 days, bowel movement every 4 days, bowel. Well, so there's a lot of bowel slowing. There's a lot of bowel complications in the geriatric population that's not related to diverticulitis. So if they get diverticulitis and they end up with a bowel obstruction from it, you might not know the difference. They may not want to report abdominal pain or blood in the stool because a lot of the elder population have got fear of complications of abdominal surgery. A lot of them have a fear of getting an ostomy, which actually doesn't happen that often with diverticulitis. The diagnostic criteria. Gold standard for diagnosis of acute diverticulitis is a physical exam showing abdominal pain and tenderness, followed up by a contrast CT, which shows the pouching, the diverticulosis, and wall thickening greater than 4 millimeters. You can see on the contrast scan below, it's clear on the one that has the darkened area from the contrast. The bowel that's on the left-hand side of B, those nice rounded loops that you can see on the left, that's normal bowel. On the right, where you get that kind of fragmented scatter dot kind of appearance, that's because you've got thickened wall, and they can measure that. So diagnosis for testing. Patients with acute diverticulosis may have an elevated C-reactive protein and mild leukocytosis, although you can end up with mild leukocytosis from a lot of conditions, so that's not very specific. Abdominal CT scan with oral contrast is the gold standard. They're looking for bowel wall thickening 4 millimeters. They can also spot increased soft tissue and fat around it, it kind of attempts to close in around any place where you get a perforation, so it's sort of like it's attempting to plug the hole from the outside. As far as what we educate patients on, common disease occurs more with aging. If you have diverticulitis, it's a good idea to eat a lot of fiber after your symptoms to kind of clear you out after you're done. Fruits, oats, beans, peas, leafy vegetables. You don't need to avoid nuts and seeds and popcorn. Smoking, drinking, and obesity are all risk factors, so a program of exercise coupled with alcohol and tobacco cessation programs are recommended by the Mayo Clinic. If you have diverticulitis once, you're at a point where they're probably going to recommend that you have more frequent colonoscopies than the average bear going forward after you have an acute episode, because it indicated that you had a problem once. Medical management. Most diverticular disease is managed by lifestyle changes and symptom management. They used to, this is old information, so if you hear this, know that it's old. They used to have antibiotics as the cornerstone for diverticulitis. However, it's not supported by science. Basically, patients are managed with oral analgesics, acetaminophen, ibuprofen. The pain's significant. Limited script for oxycodone might be appropriate. They recommend going to a gentler liquid diet and then advance it after 2 or 3 days and then weekly until all the symptoms are gone. That's your outpatient. 15% of the patients have a significant problem with their diverticulitis. They get that abscess that has to be drained. They get the fistula. They get a significant hole that has to be plugged. If the diverticulosis is a perf, then what they normally do is they surgically go in. They cut out the damaged portion of the colon and they anastomosis it back together. They don't normally leave them separated with an ostomy. After successful treatment of acute diverticulosis or litis, that's where they had bleeding. They should be checked out 6 to 8 weeks to make sure that they are symptom-free and they just didn't have symptom regression because you put them on a liquid diet, so they had less complications. And then when they go back to eating regular food, it comes back. If you're symptom-free, you should schedule to have a colonoscopy to look at your colon internally to make sure that the diverticulitis isn't actually cancerous growths and bleeding from highly vascular cancer tumor tissue. So my genius questions are, how would you address the concerns of a patient who absolutely does not want an ostomy? How do you handle an outpatient liquid diet recommendation and diet advancement for a patient that's going to be treated at home? And what is your criteria for referral to a specialist for diverticulitis issues? Basically, I'm looking to see if you have an idea or a recommendation of where you would decide it needs to be a specialist. Lots